Hello, my name is Dr. Gulzar Khan. I am a consultant gastroenterologist and hepatologist. Today, I will discuss a very interesting case of perinephric abscess, induced reno-duodenal fistula, diagnosed endoscopically and resulting in significant changes in surgical management. So, as we know that reno-enteric fistula are uncommon and are most frequently associated with chronic infections, renal calculi, malignancy, or severe inflammatory process. Reno-duodenal fistula formation secondary to perinephric abscess is particularly rare. Early recognition is critical as management differs substantially from primary GI cause of bleeding or infection. So, a 22-year-old female with sepsis and AKI, she was presented with deranged urea creatinine electrolytes after ultrasound, abdomen, and KUB. She was diagnosed as a case of perinephric abscess on the right side of the kidney, and subsequently then during hospitalization she developed fresh bleeding PR with sudden drop in HP up to 5 gram per deciliter, requiring urgent blood transfusion. She was referred to gastroenterology evaluation to identify a possible GI source of bleeding. After initial stabilization, upper GI endoscopy was planned. So this is the video of that female with perinephric abscess. You can see a fistulous trach and uh, at the junction of first and second part of the duodenum. You can see a fraying purulent material coming through that fistulous opening into the duodenum. You can see the pus and the blood are mixed and they are reflexing back into the duodenum. You can also see some injectesias, dilated vessels over there, and this you can also appreciate these reflexing back into the stomach. You can see edematous in large left kidney and the stone in the right kidney causing mild hydronephrosis, and you can see the ear specs fluid collection in the right kidney. Although endoscopic closure with clips could have been attempted, this would have only addressed only the luminal opening and not underlying the infected renal source. Given the active sepsis, cost consideration, and the need for definitive source control, a multidisciplinary decision was made. So, after discussing these with my radiology clinic colleagues and surgeon, it was decided that the patient should go for surgical excision of the fistulous trach, as well as they were planning for nephrectomy as well. So they decided to excise the fistulous trach as well. So the patient underwent definitive surgical management with good post-operative recovery, and GI bleed and sepsis was successfully controlled. So this case highlight the diagnostic value of high quality endoscopy in identifying extraluminal pathology, the importance of considering infection-related fistulas, and the role of multidisciplinary management in complex reno-enteric fistulous disease.